Hi, good evening, everyone. It's just gone 7 o'clock. Can someone just throw in the chat whether you can hear me? Great. Thank you very much indeed, folks. That's good to hear. So welcome back. Welcome to those of you that we've seen before. So tonight we are doing the next in a little mini-series of pathophysiology subjects. So we're going to be looking at the central nervous system tonight. And a few diseases that can arise within it. So we're going to look at strokes and TIAs, going to look at seizures and meningitis tonight. It's not going to be the longest of lectures. There's not huge amounts at this level to understand about these. It's more just kind of recognising and knowing what best to do for those groups of patients. So welcome along. Those of you that are new, I did see a couple of new names that I didn't recognise. So welcome along. Thanks for joining us. We are STC Training Solutions. We're a FREC provider based in the southeast. We have our main training base in Aylesbury, and we have been since around just over a year now. We've been producing on and off some weekly free webinars to help those of you going through the FREC pathway, and we've also done an ECG series. But this series that we're doing at the moment is a rerun actually, but we're just kind of adding to it, and it's for those of you travelling through the FREC pathway, whether you be doing FREC 3, 4, 5, or looking at studying as a paramedic. Hopefully you'll find these webinars useful. So we've been covering a few subjects so far. We're in the middle of a mini-series, as I say, on pathophysiology, so the study of disease, and then we're going on to some other useful bits and pieces, which are aimed specifically at those of you kind of joining for FREC 4, of course, but they will be useful revision for those of you going on higher, and those of you that haven't started at all, of course. So that being said, we are a FREC provider. Here's some of our courses. We've got a busy month in August, actually. So July. We do have a busy month in August as well, but we have a busy month coming up in July. A lot of these courses are filling up. So if you do want to come and join us for your FREC 3, FREC 4, your ILS or your SARM, then please do get in touch. We only have a couple of spaces left on those two FREC 3 courses. So if you want to come on one of those, so we have a weekend course starting on the 31st of July, runs over 3 consecutive weekends. We have a Monday to Friday course starting on the 12th of July. I think there's only 1 or 2 spaces left on that one. And then we have a FREC 4, if that's more your flavour, that starts on the 10th of July. We run our FREC 4s the way Qualsafe designed them to be run, which is over 3 blocks. So they run over 7 weeks in total, but you only actually join us for 3 weekends of that. And in between, you complete your workbooks, which kind of helps guide your study, and a much more gentlemanly way of doing it than Monday to Friday. We also have an ILS course coming up. We do the Qualsafe level 4 ILS. We've got one of those coming up on the 27th of June. We are switching to the Pro Trainings level 3 ILS, which we'll be able to do for a much more competitive price. So keep an eye out for that if that's something you're interested in as well. We are doing our SARM course as well. SARM course has been really popular. There's only 1 space left, I think, on our next SARM course. That starts on the 17th of July, just over 1 weekend. That's a really good add-on for those of you that have FREC 4 already and are looking at getting some additional work in the kind of private event side of things. The SARM definitely adds a good skill set to you. Those of you that join us through the webinars can use our discount code there. So webinar 10 gets you 10% off any of our courses. So pop that in the checkout on our website if you decide to book. We hope to see you in future in real life, of course. So those of you just joining, haven't missed anything, welcome along. It's just gone 7 o'clock, so here we are then. Those of you that haven't joined us so far, this series has already covered CPD requirements of the FREC students. We've already covered some anatomy and physiology. We're now going through pathophysiology, which, as I say, is the study of some certain diseases. And then next, we're going to be going on to some maternity care, which I'm quite excited about. We've got patient assessment. We've got some paediatric assessment help coming up. We've got a session on sepsis, some sessions on oxygen and Entonox, and another ECG kind of run for those of you that don't want to go into huge amounts of detail at this stage. We're going to do a basic ECG session that goes to the level required of FREC 4. And then we're going to talk about some immediate life support. Again, it's not going to be in place of your face-to-face requirement for your FREC 4, but if you want to keep your hand in between, you're more than welcome to join us for the ILS session, which will be towards the end of the session. If you want to suggest any material at any point, please do just drop us an email and we'll pop it on the list. If there's enough interest for things, we'll certainly run an extra session here and there. So tonight's session now, as I say, neurological, we're not going to be talking for hours tonight. This is a relatively short session. Strokes and TIAs, what are they, what's the difference? Seizures, meningitis, and of course how we're going to treat all of those subjects, and then there'll be the usual Q&A session at the end if there's anything you want to ask. So how can we make this interactive? We like our sessions to be interactive. Those of you that have joined us before know that we like to try and make use of Mentimeter. So grab your smartphones, make sure you've got access to the internet and go to menti.com. It'll ask you for a code. We'll give that nearer the time when we get to the questions we want you to ask. Feel free to pop anything in the chat. Charlotte's working tonight, she's out on an ambulance, so it's just me, so I'll do my best to answer any questions that come in. I've got the chat box open. If you're having any problems, do let me know. And if you've got any questions as we go along, throw them in the chat. If I end up answering them, then that's fine, and if I don't, I'll go back and read them and do my best to answer them. If you think of something afterwards, though, you can always text us, email us, tweet us, etc. We would like it if you can check in with us tonight. It does help us kind of become more out there. I don't pretend to understand social media as much as others do, but apparently if you check in and tag us in things, it makes us more visible. So, and of course, these webinars are free, but of course, if we can turn them into people actually coming and booking courses with us, that's always going to be really gratefully received. So there is some recommended reading with anything to do with pathophysiology. We recommend these books. Ambulance Care Essentials over on the left is the recommended reading for FREC 3. Those of you that have done FREC 3 should have a copy of that from your provider. If you have done FREC 4, you should have been given Ambulance Care Practice over on the right. They're the kind of core FREC textbooks. If you haven't got copies, if you want them, they are available from our website with free postage. We do also recommend Ross and Wilson, the Anatomy and Physiology textbook, and the Pathophysiology, a Practical Approach by Rachel Story. I find it's very useful if you want to study certain diseases in more detail. Just bear in mind, Pathophysiology and the Anatomy and Physiology books do go into a lot more detail than you need to know for FREC 4, which is where we're kind of pitching these webinars. But of course, that's not to say that you can't have an interest in a particular area and want to study that in more detail. So this is a recommended reading. If you'd like to buy any of those books, as I say, they are available on our website. So let's go over to Mentimeter. Let's see if it's awake this evening. I'm just going to change my screen share. Sorry, we're having a slow computer tonight. There we go. So head over to menti.com. Use the code 96949086. It's the number shown at the top of your screen. 96949086. If you put that in at menti.com, you'll be asked the question, what are the functions of the central nervous system? You can put up to 3 answers. Let's see how much you remember from your A&P. So go to menti.com, instructions are at the top of the screen, go to menti.com, put in the code 96949086 when you are prompted, and it will allow you to answer this question. Who's going to be first? There we go. Wonderful, it's starting to come in now. Brilliant. So control breathing, control most things. To control movement, activating muscles, control movement, breathing, sending pain, locomotion. I like locomotion, that's a good word. To control most things. That's always good. Motor, sensory, good. We're using some buzzwords there, aren't we? Anyone else want to throw in some words? Locomotion's come up again. Excellent. Locomotion, lots of people going for that now. It's a good word. Metabolism, yeah, good. It does have some control in some ways in metabolism, but good. Sending pain, sensory signals. Lovely. We're getting the basics there, aren't we? Functions of the nervous system, absolutely. So they are all about control. It's broadly broken down into sensory, the sensory side of things. So there's lots and lots of nerves around the body that sense what's going on around the body. Some things we're aware of, some things we're not aware of. From there, it goes up into the central nervous system, which is the brain and spinal cord, and from there, decisions are made. Now, some reflexes are in the spinal cord itself, so the signal doesn't actually reach the brain. The reflex centers within the spinal cord deal with the sensory input and control something. That's the third function. So ultimately, we sense things, we make sense of them, we make a decision based on what we're sensing, and then we instruct something to do things, and that's the motor side of the nervous system. So sensory senses things, motor does things, and the central nervous system, the brain and spinal cord are the main systems in which those decisions are made. Of course, the vast majority of decisions are made by the brain, but it's always just worth bearing in mind that your reflexes often occur in the spinal cord. If you were to touch a hot stove, for example, you would pull away before you were aware that you'd even pulled away, and that's because the spinal cord is making the decision for you, and it's not actually reaching the cerebral cortex, which is your kind of conscious level of awareness. But good, absolutely, we're getting some of those buzzwords, and of course, movement is a huge part of the somatic nervous system, isn't it? Of the nervous system that we're aware of, the motor area of the brain in which we control our movement, all of the movement, talking, and I like that we've got some other words in there. So I like that we've got bits about digestion and metabolism, etc. That is obviously a function of the sympathetic and parasympathetic nervous systems. Sympathetic is the fight and flight, parasympathetic is the rest and digest. If you're having trouble remembering which way around those are, parasympathetic sounds like paramedic. I think paramedics are there to calm people down. The parasympathetic nervous system should do the same. That was what I was taught. That's how I remembered it back in the beginning, and I think that's stuck with me. So let's go back to the slide. So this is the nervous system. This is what it looks like. You have the brain and spinal cord there in purple. They are the central nervous system. Everything outside of that is the peripheral nervous system, broadly broken down into the cranial nerves here up in the face, and the spinal nerves, which obviously come off the spinal cord and control all parts of the body. Okay, so we sense and control just about everything in the body from the central nervous system in one way or another. There's a vast majority of decisions made by the brain. The further up the brain it goes, the more aware we are of those decisions, and those made in the spinal cord are generally only reflexes. Here's what the brain does. So the cerebrum is the main part of the brain. As I say, that outer layer, the cerebral cortex, is our conscious thought. So those are things that we're aware of. Everything else is unconscious decision making. The encephalon is the word given to this kind of center of the brain. It's made up of the hypothalamus, thalamus, and the pineal gland, which is part of the epithalamus. And then the brain stems out from there with the cerebellum, the kind of mini brain, which is responsible for a lot of our balance centers and things like that, pokes out at the back. And then you have the three areas of the midbrain, the brain stem, the midbrain, the pons, and the medulla oblongata, which is where a lot of the main control of breathing. Somebody put control of breathing on the answers, didn't they? That's all done within the brain stem. The most important decisions being made by the body are often down in that deep in the brain within the pons or medulla oblongata. Good. Here's our friend the neuron, isn't it? So neurons, they take all different kind of looks, but this is a general overview of one. We have the cell body. The cell body you can recognize because it's the one with the nucleus. So we have dendrites. Dendrites receive signals from either from brain cells or from other neurons. Neurons can talk to each other. So signals are received by the neuron through the dendrites, and then they travel down the axon. So this is a unipolar, a one-way neuron that we're looking at here. So the electrical signal is transmitted like wiring in your house from the dendrite all the way down the axon to those synapses, or the synaptic end bulbs or axon terminals, or whatever you've been told that they're called. The end of the axons is where the signal is going to. Now those what are labeled as synapses on this one are connected either to the target cell. So let's say, for example, this cell is responsible for wiggling my toe. Let's say I have to make a conscious decision to wiggle my toe. So that signal is sent by a brain cell in my cerebral cortex. I say my toe wiggling center, if there is such a thing, but if not, I'm going to paste it. It'll be the Eaton center, perhaps. The toe wiggling center sends electrical signal to the axis or the dendrite of the neuron responsible for toe wiggling. And from there, it travels down the axon. That axon is very, very long, don't forget. And this is what I didn't realize at first when I first learned about neurology and got myself a little bit confused, was that actually these nerves can be really, really long, okay? In theory, you know, one end could be up in the brain, the other end could be down in the toe. Now, that's not strictly true, as you'll learn more and more about the nervous system, but these are very, very long axons, okay? What you'll see is they have things called synapses and ganglion, where nerves connect from one to another in bulk, if you like, so like a big junction box in your home wiring system. So there's very few nerves that are actually truly that long, but they're a lot longer than you think they're going to be anyway. So that signal goes all the way down to my toe, and the synaptic end bulb or the axon terminal down in my toe sends the signal to the toe muscle, and the toe muscle wiggles. And then don't forget, there's for each action there's an equal and opposite reaction. It's the same for the electrical circuit of the nervous system. There has to be a return feed. When I wiggle my toe, I'm aware that I'm wiggling my toe, so there obviously has to be some sensory there, doesn't there? So there's a sensory neuron going in the opposite direction with its dendrites down in my toe and its axon terminals or synaptic end bulbs up in my brain. And that goes back to the toe wiggling center to say, yep, job done. But see how quickly that is. You're wiggling your toes now, I bet you. And you're thinking, oh yeah, I'm aware that I'm doing it. But how quickly does that happen? You say, I'm going to wiggle my toe and it's happening. And you're also aware that it's happening. So this is very, very quick. The whole function of the nervous system is rapid communication. Where things don't need to be communicated so rapidly, or where we need to tell lots and lots of people to do things, we use the endocrine system, having a mind blank there. We use hormones, we use endocrine signals, which is where we send a load of hormones into the blood. That blood circulates around and it tells lots and lots of people to do things. So, for example, insulin in diabetes, you know, it doesn't, not in diabetes, in anyone. Insulin is released into the blood to reduce our blood sugar levels. If the nervous system did that, it would have to have millions of neurons, because it would have to go to all the individual cells and say, open the doors and let the glucose in. But insulin does that by being circulated in the blood. So the central nervous system is for telling small target areas what to do very, very quickly, as opposed to the endocrine system, which is telling lots of areas what to do, but it's not as quick. It takes a little while to secrete hormones. Good. Hopefully that makes sense. There's a few terminology kind of things with the nervous system that always make people's head hurt a little bit. The axon itself is insulated. Just think of it that way. In the same way that household wiring is insulated with plastic, the axon, which you can consider being copper wire if you like, is insulated with these things called Schwann cells. Schwann cells and myelin sheath. Sorry, so it's actually insulated with myelin sheath. Schwann cells are the cells that produce that myelin sheath, and the myelin sheath is what gives them that kind of white appearance, the light grey appearance. Okay, so that's the insulation. In between them, they do have these little gaps called the nodes of Ranvier, which I love. I love that word. Nodes, or the name for that. It sounds like somewhere you'd go in northern France with the tent, doesn't it? But on weather like this, I'd love to be doing that. But these are just insulated ways of insulating those cables traveling from one place to another, so they don't interact with each other. And don't forget, multiple sclerosis is exactly what you think. Multiple sclerosis is degeneration or demyelination. So that myelin sheath disappearing, and those electrical signals start to short circuit and cause loads of problems. So. Good. So that's the kind of functions of the nervous system. So we're going to go back to our next question on here then, which is now, what is the difference between a stroke and a TIA? We're going to start with strokes and TIAs tonight. Tell me what you think the difference is. So back to menti.com, it's the same code, 96949086. Have a little go, up to 3 answers. Well, you can only put one if you like. There we go. Stroke long lasting, TIA resolves in 24 hours. TIA is transient. Ooh, that's a good word. TIA resolves, damage, time. Someone's done a course with us. Who put time? Good. TIA is temporary. Good. Brilliant. Excellent. Area of damage. Sometimes. TIA is transient. Full resolution in TIA. Stroke can be permanent. TIA doesn't cause permanent damage. TIA resolves. Brilliant. The difference is time. Whoever put that obviously came on one of our courses. I go on about this. What's the difference between lots and lots of things in medicine? It's time. So the difference between stroke and TIA is indeed time. Good. TIA resolves, blood vessel ischemia, stroke is complete, stroke long lasting. People are getting the gist of this. This is good. Okay, I like it. So you're obviously knowledgeable folk out there. So the difference is that TIAs resolve by definition. They're called transient ischemic attacks. Okay, they are strokes that self-resolve within 24 hours. Absolutely, guys. Well done. Perfect. The difference is time. So let's flip back to our PowerPoint. So I just want you so you don't need to memorize any of this stuff. This is a picture of something called the Circle of Willis. The Circle of Willis is the kind of blood distribution system for the brain. So you have two carotid arteries that pop up from the aorta effectively through a few different junctions. So you have two main carotid arteries coming up to the brain, and they supply the Circle of Willis. So the Circle of Willis is effectively a really complex distribution system that allows the brain to receive blood all over the place. It's brilliant. It works very well. What we're interested in here is the blood supply, because actually what a stroke and a TIA have in common is it's an interruption of the blood supply to part of the brain. Okay, if you interrupted blood supply to the whole brain, you would just die. There's no kind of halfway house there. So a stroke and a TIA, they have in similarity is that a part of the brain has had its blood supply interrupted. Now the brain isn't particularly good at storing oxygen, glucose, etc. I mean, no cell in the body particularly is, but the brain is terrible at it because it has such a high oxygen and glucose demand. So when you cut off blood supply to a part of the brain, it will show symptoms of straight away. That part of the brain will switch off until such time as it's resupplied with oxygen, reperfused, or it dies because of lack of oxygen. Okay, so the Circle of Willis, the one other thing you can kind of be aware of there is you get sometimes things called berry aneurysms. Berry as in things that grow on trees. So berry aneurysms are as they sound like they should look like. They look like little berries hanging off this Circle of Willis, little kind of lumps and thinnings of the artery. So they can become thin and weakened, and sometimes actually with high blood pressure and stress and other things they can pop. So when we talk about hemorrhagic strokes a little bit later, sometimes, or the most common cause of hemorrhagic stroke is a burst berry aneurysm, and they commonly occur down here in the Circle of Willis. So this is the bottom of the brain looking up, if that makes sense. So we're looking, if you chop someone's head off and looked up the hole in the bottom of their skull, I don't suggest you do that. That's not part of FREC 4 training, but if you were ever to be in a situation where you cut someone's head off, then have a look up there and you might see the Circle of Willis before you get arrested. Quite interesting. So that's the main blood supply to the brain. Berry aneurysms commonly occur there. If they pop, you lose blood and you have a hemorrhagic stroke, and we'll show you what all of that means. I'm going to talk a little bit more anatomy again. Certainly don't need to learn the names of all of this. I just want you to be aware of some of the anatomy around the brain. This is looking at the top of the skull. The false cerebri is the area in the middle of the brain that divides left and right. So we're looking at the kind of top middle of the brain, looking front to back or back to front. And you can see that there are there's bone, the skin on the outside of that bone, the bone being the big white chunky bit in the middle, and the brain being the kind of innermost layer. So that brain has three protective layers. They're known as the meninges. So you have the pia mater, the arachnoid mater, and the dura mater. The dura mater is technically made up of two different layers, but it's considered to be one, effectively, one outer protective, tough fibrous layer. You have the arachnoid mater that is the kind of middle layer. It's called the arachnoid mater because it has these little spider's legs that dangle down towards the brain. And the purpose of that is this is where a lot of the CSF, cerebrospinal fluid, is created and stored. And also this is where a lot of the blood supply is kind of travels around the brain. Some of the venous return to the sinuses is also within the arachnoid mater, and then the pia mater is a thin inner protective layer that's kind of super glued to the top of the brain itself, or the brain itself. Now this is the same story down in the spinal cord as well. Okay, so you still have the three layers of meninges. You just don't have that outer periosteal layer of the dura mater. That's the only difference in the spinal cord. But you still have 3 layers of meninges. Cerebrospinal fluid circulates within the subarachnoid space. When we talk about where things are in the brain, we talk about where they are in relation to the meninges. That's why it's important to know what they are. So something that's outside of the dura mater, so between the skull and the dura mater, would be extradural. You may have heard of extradural hematoma or hemorrhage. Anything that's underneath the dura but outside of the arachnoid mater is called the subdural space. So the subdural hematoma, subdural hemorrhages. Of course, anything underneath the arachnoid mater. So it's subarachnoid hemorrhage, subarachnoid hematomas. So and the subarachnoid space is where you find your cerebrospinal fluid. There's generally nothing sub-pier, so anything that would be an intracranial or intracerebral hemorrhage if the brain were to be bleeding actually inside the pia mater within the brain itself. Good, and the circle of Willis sits within the arachnoid mater, so if you get the burst aneurysms, you're going to get blood within the subarachnoid space. It'll be a subarachnoid hemorrhage if one of those aneurysms on the circle of Willis burst. Subarachnoid hemorrhages, I think, are by some margin the most common of the brain bleeds. They can be spontaneous, like as I say, a aneurysm going, or they can be traumatic. You can see there in this diagram, you've got blood vessels within that subarachnoid space. If you shake the brain about too much in a traumatic head injury, you can shear those vessels. Particularly later in life, and particularly those that are alcohol dependent, they tend to have smaller brains and bigger subarachnoid spaces, and the blood vessels within those spaces get stretched. And obviously under tension, they're more likely to snap. So head injuries in alcoholics, head injuries in the older generation are a little bit more concerning. Subdural and extradural and subdural hemorrhages tend to be a thing of trauma, but of course it is always possible that they happen spontaneously if a blood vessel in those spaces were to burst for whatever reason. So we're talking a lot about bleeds, but actually most strokes are what we call ischemic, and that's where the blood vessel is blocked for one reason or another. They haven't actually bled. So we're going to talk about the 2 types here now. So blood flow can be reduced for 2 reasons, as I say. So occlusion of the blood supply in ischemic stroke, around 85% of adult strokes, most you don't really have children having strokes, 85% of strokes are ischemic. Now ischemic is a blockage in the blood vessel. So those of you that joined us last time, a couple of weeks ago, for the cardiovascular system, or remember we talked about acute coronary syndrome where clots block up the coronary arteries. This effectively, and for some time, was called a brain attack. Don't forget, strokes used to be called brain attacks to try and get people to understand that they were the same as heart attacks. So a blockage in one of the smaller arteries supplying a part of the brain is going to be called an ischemic stroke. Now that's normally clots. And normally that's kind of made worse by fatty deposits building up over time in exactly the same way as they do in our coronary arteries. One of the causes of vascular dementia is, build up of fatty deposits to the point where the brain is receiving a reduced blood flow. So much like angina of the heart, vascular dementia is effectively angina of the brain, but they're constantly, isn't it? So if you were to throw a clot into the mix and block off a small artery that supplied a part of the brain, that part of the brain would immediately switch off. Likewise, if you cut a blood vessel, if a aneurysm bursts or another small blood vessel supplying a small part of the brain were to burst, then of course anything downstream of that is not going to receive adequate blood supply perhaps. So that part of the brain is going to shut off. But of course with hemorrhagic strokes you also have the problem of how do you get rid of the blood. The skull is a sealed container. Ultimately, spontaneous subarachnoid hemorrhages, the pressures can build up quite quickly. As blood floods into that subarachnoid space, it starts to compress the brain. The brain has nowhere to go other than out through the foramen magnum, which is the big hole at the bottom of the skull. If you start to do that, it's called coning. Coning is not very good for you. It starts to squeeze the brain stem, and we said earlier on, the brain stem is where a lot of your major organ control systems are held, certainly for the heart and lungs. And levels of consciousness, etc. So if you start squeezing the brain down onto its midbrain and pons, medulla, etc., you're likely to start causing problems in that respect. And we will talk about something called Cushing's triad. It's a little bit over and above what we're expected to know for FREC 4, but I think it just helps to reinforce what is going on in these situations. So ischemic strokes are bad enough because obviously that part of the brain is not getting any blood. After a certain amount of time, that's going to die. Hemorrhagic strokes, though, have both that issue and the more compounding issue of actually how do you get rid of that blood and all that excess pressure before the brain starts to become irreparably damaged from excess pressure, as well as being ischemic in certain areas. So, and quite literally drilling into the skull is what the neurosurgeons do, don't they? Get the Black & Deckers out and make a little hole and release the pressure. Thankfully, it's a little bit more controlled than that, and I certainly wouldn't want to be the one holding the drill. So I've just said there again, hemorrhagic strokes are described in relation to the meninges, so where they happen, you would call it extradural or epidural, subdural or subarachnoid, depending on where the bleed was happening. So your transient ischemic attack. So by definition, it is transient. So it means it comes and goes. Ischemic means it can only be ischemic. Remember, we've just said there's two types of stroke, ischemic and hemorrhagic. Thinking about it logically, can you have a transient brain bleed? No, be honest, you bleed a little bit into your retinal space. It's not just suddenly going to get better. You actually have to remove that blood somehow. Whereas a clot can lodge and then it can dislodge. It can travel on to somewhere else in the system. So a transient ischemic attack, it's transient, it will come and go. It has to be ischemic. You can't have a transient hemorrhagic attack. An attack obviously just meaning it's affecting the brain. So it's stroke symptoms that fully recover in 24 hours. Next question is, are you going to stay on scene with somebody with stroke symptoms for 24 hours to decide whether or not it's a TIA? 23 hours, 59 minutes, and yeah, no, you're actually having a stroke. Let's take you to hospital. No, because obviously at that point the damage is done. The brain isn't going to last 24 hours. So whenever we have a patient sitting in front of us with stroke symptoms, we'll come on to these. Obviously, we're going to treat it as a stroke. I was going to say it's still often called cerebrovascular accident as well. CVA, stroke and CVA are the same. Cerebrovascular accident, and CVA is a bit of an old-fashioned term. They want us to stop using CVA, but it's still, you'll see it written down quite commonly. Stroke is the term they want us to use. Stroke and TIA. Good. The TIA pathways vary, but basically they need to be assessed by somebody suitable within 24 hours of onset. That is normally going to be the patient's GP or the TIA clinic, depending on which area you work in. As I say, the golden rule here is you can't differentiate between them whilst the patient has symptoms. If you've got any doubt at all, just treat it as a stroke. It says here, call 999 immediately. If you are 999, you don't need to do that. Just take them to a stroke unit. We'll talk about some of the timings and things like that. So the FAST test, hopefully everybody's heard of the FAST test. It's the face, arms, speech, and time to call 999. I can see that there's some stuff in the media again about strokes, isn't there? I think trying to improve public awareness of stroke symptoms again. So facial weakness, if your face falls on one side, if you're unable to raise an arm, if you're unable to speak without slurring your words, then it's time to call 999. For us, time, T of time means when was the onset. We need to know specifically when did these symptoms start. Now, depending on where you work, again, things will change slightly. I work for two different ambulance trusts. One is the rule is less than 4.5 hours. So if the stroke symptoms started less than 4.5 hours ago, we go blue lights to the hyperacute stroke unit, the HASI, and they go straight to CT. They try and figure out what's going on, and then they administer the correct treatment in hospital. The other trust I work for is 4 hours, but that's because our running times normally to stroke units are a little bit further in that trust. So we have a slightly shorter window. Outside of 4 hours, it doesn't mean we don't treat them. It just means we still take them to the stroke unit, but we don't necessarily go there on blue lights and sirens, because ultimately it's no longer time critical. That after 4 hours of ischemia, that brain is dead. And ultimately that patient just needs stroke rehab rather than acute kind of thrombolytic treatment. Thrombolytic meaning breakdown of blood clots in ischemic. Obviously, if we're thinking that they have a brain bleed, actually that patient needs neurosurgery. Now, not all stroke units have neurosurgeons, but at the end of the day, that's as an ambulance service, we would struggle to keep up to date with which hospitals have what services. We struggle anyway, so don't throw in neurosurgeons as well into the mix. Ultimately, if you're thinking if they're having a brain bleed as the cause of the stroke, I mean, you sometimes get a bit of a feel for which one it's likely to be. You still go to the stroke unit unless your local pathway tells you otherwise. I know in London, one of the trusts I work for, they don't specify really. If you have a patient with a suspected bleed, if you're fairly certain it's a bleed, there are a couple of our stroke units that do have neurosurgery. There's a couple of stroke units that don't. If provided journey times aren't going to be too massively long, you'd potentially go to. But again, it's always a judgment call on the day, and your local guidelines are going to change. And at this level, I wouldn't have thought you'd be the only one making the decision. I would hope that somebody would be there to support you with those types of decisions, but you won't go far wrong if you take them to a hyperacute stroke unit. And as I say, if the onset has been within the last 4.5 hours, depending on where you work, you would normally go there on blue lights as a time critical emergency. So, and help that patient out. So we've had a question on how do brain bleeds, I'm assuming, or how do strokes impact on patient temperatures? They don't generally. So temperature is controlled by the hypothalamus, and often the hypothalamus isn't generally affected by strokes. I would suggest if the hypothalamus was one of the areas that was becoming ischemic, temperature would eventually, or I suppose generally, when you're alive, you're generally down regulating your temperature. So your temperature would come up slightly, but that's not going to happen immediately. That's going to be over a period of days, I should imagine. But I've never noticed anyone's temperature change in either ischemic or hemorrhagic stroke. Good. Recognition features of a stroke then. So we're thinking fast test, aren't we? So normal, but may have slurred speech to response. Airway would generally be normal. Breathing would generally be normal. May become irregular in hemorrhagic stroke. I'm just going to talk about that. Heart rate may be normal, or again, may become bradycardic, particularly in those hemorrhagic strokes. Blood pressure may be normal, or again, it may rise again in hemorrhagic strokes. That is your Cushing's triad, okay? When you hear this term Cushing's triad, that's altered breathing, raised blood pressure, and bradycardia. Now that is because the bottom of the brain is being squeezed, and that's where these three things are controlled. Your respiratory and your cardiovascular centers are within the midbrain, within the brainstem, within the pons and medulla. Having brain blanks tonight. So the respiratory and cardiovascular centers start to become affected as the brain gets squeezed. This is generally speaking only going on in hemorrhagic strokes where there's a significant rise in intracranial pressure and that brain is being squeezed out of the foramen magnum. So the three things to look at are altered breathing, so irregular breathing patterns, sometimes called chain state breathing, particularly in the later stages. We often see raised blood pressure, so significantly raised. We're talking like 200 over 120, silly figures like that. And bradycardia. Bradycardia can result from the sensors not sending signals down to the SA node. Good. GCS may reduce again in severe cases. Certainly, when your intracranial pressures are rising, you're going to lose levels of consciousness. Your blood sugar should be normal. Fast test obviously is going to be positive. There may be some pupil changes. We often see what's called a blown pupil, so one pupil being big and not responding. As I say there, so temperature is often normal. I've not associated any temperature changes with strokes in the past. Nausea and vomiting is quite common again, and particularly with increased intracranial pressure when with bleeds on the brain. So, but again, nausea and vomiting can result from severe strokes as well, ischemic strokes as well. Treatment for stroke, nice and simple really. There's nothing really to be done pre-hospitally. Calm and reassure, move into a quiet environment as possible as you would for all patients. Definitely get your fast test documented. There is no pre-hospital treatment for stroke. Time is brain though. Okay, that's the phrase, like time is myocardium for heart attacks. The longer you stay on scene, the more of their brain is dying, so get them to hospital. Do monitor them closely and rapid transport to the appropriate facility. That will depend on your local guidelines. Requesting senior clinical support is really useful. There's nothing I can do as a paramedic that you can't do as FREC 4. And if you're suspecting TIAs, then get in touch with the clinical desk. There may be pathways for you to follow, but generally they're only open to paramedics and EMT grade, the local TIA pathways. On the subject of completing a fast test and completing some observations, in a lot of stroke units will not accept a patient on the pre-alert unless you give them the blood sugar. That's because low blood sugar can mimic a stroke. So if you're suspecting stroke, please always take their blood glucose. If their blood glucose is low, correct it before you call it a stroke. Stroke units, as I say, if you don't give them the blood glucose, they'll ask you for it. If you haven't got one, they'll often refuse it until you can get one. So just bear that in mind. So we'll flick back to Mentimeter then. Oops, what's going on here? No, wrong one. New share. Sorry, we're having a moment. So we all see menti.com. Fab. Okay, so next question on menti.com then, same number, 96949086. We've got a multiple choice question. How much oxygen do we give a stroke? None, 40%, as required based on SATs, or 100%? So menti.com, 96949086, A, B, C, or D? I'll let kind of half of you have a go.
Here's You Have One Again by Travis Hire on Amazon Music.
Alexa, stop. I don't know why Alexa thought that was cue to start playing music, but hey. Fab, let's see where we're all going. So 82% of you going for as required, 8% of you going for none, 15% of you going for 100%. Well done, 77% of you. Stroke. Stroke is only, it's one of those kind of severe illnesses that only requires oxygen if the patient's hypoxemic. It's your orange box guidance in gel calc, isn't it? So only if they're hypoxemic is the key. If the saturation is less than 94% or less than 88 if they are COPD, then we give them some oxygen. Otherwise, we leave it alone. So the reason being, same for the reason why we don't give 100% oxygen to angina and heart attack patients anymore, is actually 100% oxygen is associated with small amounts of arterioconstriction, so spasm of the arteries and slight closure of the arteries. Clearly, in both cases, heart attack and stroke, we want the arteries to be as wide as possible, don't we? So, well done to those of you. So the next question is then, we're moving on to seizures now. So what are the priorities when managing a seizure? Up to three answers. Same code, 96949086. Safety. Safety is always the main priority, isn't it? Very well done. Any advance on safety? There we go. Airway, keeping the patient safe, not to bite the tongue. So, time. Time isn't the answer to everything, whoever that is. Good. Although timing the seizure is important. But that doesn't mean time is the answer to everything. Good. Safety is obviously key, isn't it? Danger to us, to the patient, to our crewmate, to the general public. Airway management, of course, is always going to be high up there, isn't it? Breathing. So not biting the tongue, I mean, yes, it would be nice if they didn't bite the tongue, but I mean, what do we suggest we do to stop them? There's not a huge amount we can do. Preventing aspiration is good, I like that. So going to do what we can to protect their airway, keeping the patient safe and preventing the patient from injuring themselves, I think is quite a key one, isn't it? So safety for us, safety for the patient. They're likely to fall. If you witness the seizure, it might be worth trying to stop them from falling too awkwardly. And of course, looking at protecting their head as best we can when they are actually fitting. Okay, good, well done. So safety is the big one there. Let's go back to our slides. So, oops. Seizures and epilepsy then. So seizures are caused by chaotic electrical activity within the brain. Hopefully you all knew that. So if the brain is sending off electrical signals here, there and everywhere, it's going to start to cause some weird and wonderful movements, isn't it? So the patient may present with any combination of shaking, altered levels of consciousness, repetitive actions, depending on which part of the brain is affected. If the whole brain is affected, you're going to see much more generalized kind of general shaking. If you're seeing just small parts of the brain, you may still even have a patient who has a level of consciousness that is aware that they're having their kind of their partial seizure. Okay, well done. The seizures themselves usually aren't life-threatening, although it's just worth bearing in mind that sometimes they are a sign of a serious underlying illness. So we'll go through some situations in which we need to call an ambulance straight away or get senior clinical support straight away rather than waiting for the usual regulatory 5 minutes. So one of the reasons is the patient's first seizure, because actually it's much more likely to be a sign of a serious underlying illness rather than just they've randomly developed a diagnosis of epilepsy. So if the patient is pregnant or diabetic, a pregnant patient, it's eclampsia until proven otherwise. So eclampsia is life-threatening for mum and baby, so we need to get that diagnosed. Diabetic, it's a hypo until proven otherwise, so you need to check their blood sugars. Clearly, if the patient stops breathing or loses their pulse, they've gone into cardiac arrest. Okay, so the fit can be a hypoxic fit as a result of having gone into cardiac arrest. Those of you that were watching the football the other night would have seen Ericsson have a hypoxic fit as he arrested. That's quite common. Okay, so if you've got a patient that is fitting, do make sure you are certain they're breathing, and they might not be breathing particularly well, but make sure they're breathing, make sure they have a pulse. If there's been a head injury or the patient's been in water, it's important that we get them assessed. Head injury, because actually the seizure could be as a result of increasing intracranial pressure as a result of a brain bleed, so we just talked about hemorrhagic stroke. If they've been in water, it could be secondary drowning, couldn't it? So there's one thing we just need to be aware of. If the patient has a fit without fully recovering from the first, we'll go through the stages of the seizure very shortly, but basically the patients, when they come around, are often unconscious for a few minutes and then very confused for a few minutes. If the patient has another fit before they recover from that confusion, then that is a cue to call for help. Or the patient doesn't fully recover within a reasonable time frame. Most books will say around half an hour, but in practice, actually, some people can take longer than that to recover and be absolutely fine. At 30 minutes or so, if the patient hasn't fully recovered, start getting. This is your cue to either call 999 if you're out and about, or to get some senior clinical help down to you. If you are the FREC 3 or the FREC 4 on an event somewhere and somebody's had a fit. Ultimately, a lot of it's going to be decided by what the family and the next of kin and the patient themselves says. If a patient has epilepsy, has a fit every couple of weeks, and it's been a week and a half since their last fit, are we necessarily going to be as worried as somebody that's just taken a knock to the head? No, clearly not. So I think we've just got to take a little bit of context there in how we manage these seizures and how quickly we call for help and ambulances and things like that. Bearing in mind, as I say, the seizure itself is not normally a problem. Protecting the head and protecting the airway is the best thing we can do for those patients. So, two general types. So we have the partial seizures and generalized convulsions. Okay, convulsions and seizures are used interchangeably. Partial seizures, sometimes called focal seizures. You have simple and complex partials. The only difference between simple and complex is whether or not the patient retains any conscious level, so whether they are aware of their fit or if they're not. So simple partial seizures are patients that are doing repetitive actions and that they're aware they're doing it, but they can't stop it. Complex partials are there's no level of awareness or they are unconscious. Generalized convulsions, so tonic-clonic, which used to be called the grand mal seizure, is what we consider to be the classic epileptic fit. Those of you that have seen people fit and they go all rigid and fit and shake all over, is having tonic-clonic seizures, and we'll talk about the stages of those. Absent seizures can be both complex partial and they can also be generalized. They're more often considered to be generalized seizures. So the eyes open, nobody home, or the patient just completely unconscious for a few minutes and then gradually comes around again. So, there are also febrile convulsions, which aren't particularly well understood, but they're associated with a rapid rise in temperature, and normally only in children up to about the age of 6. After the age of 6, children can regulate their temperatures pretty well. Up to 5, the hypothalamus isn't fully formed and doesn't control it quite so well. So febrile convulsions often associated with a rapid rise. There's evidence out there that paracetamol ibuprofen doesn't actually help prevent febrile convulsions, but ultimately that's what they're associated with. Sometimes they can go on for a long time. Non-epileptic attack disorder, as it's now called, used to be called pseudo-seizures, still is called pseudo-seizures a lot of the time. It's psychological causes, should I say, psychological causes for seizures, not particularly well understood. So non-epileptic attack disorder, there's no physiological reason why the patient's having a fit. As I say, often called pseudo-seizure. Pseudo-seizure means literally fake seizure, but that's quite derogatory to those of you that those patients that can't actually control what they're doing. That's not to say that there aren't people out there that do pretend to fit, because there are people out there that pretend to fit. But yeah, absolutely, there are genuine cases of non-epileptic attack disorder out there, and they're treated exactly the same. So if you see someone fitting, doesn't matter whether you think it's a need or a genuine seizure, then it's still treated exactly the same. Phases of a generalized seizure then, so often they get an aura, but not always. An aura is a kind of a sense that it's coming, whether it be a strange smell, a strange taste, or just a strange sense, a sixth sense. within them that tells them it's going to happen. Often auras come with migraines as well. I used to get migraines, I used to get auras. I knew one was coming. I'm led to believe they're very, very similar in epileptic seizures as well. The tonic phase is the muscle rigidity. The patient goes rigid. If they're standing, they're going to fall. That's the time to try and catch them without injuring yourself, if you can, if you're there when it happens. And then, of course, the clonic phase is the rhythmic jerking, which can last anything up to sort of 2-3 minutes typically, followed by the postictal phase. The postictal phase is the initial unconsciousness and then the confusion, disorientation, slow general recovery back to GCS-15, back to normal kind of levels of consciousness. Typically lasts around 30 minutes, as we always say. That's patient specific. Those that fit all the time will have shorter postictal phases. Those that don't fit very often will generally have longer ones. Anything over 30 minutes, I would start to be asking for help, because if they're not recovering properly, their chances of having another fit are increased. So we have this term of status epilepticus. Now, status epilepticus is a life-threatening emergency, and it's defined by a prolonged seizure. A prolonged seizure is going on for more than 30 minutes, or repetitive seizures that don't fully recover within that time frame. So if you have a patient that fits, starts to recover, fits, starts to recover, fits, starts to recover. If it goes on for more than 30 minutes, that would be defined as status epilepticus as well. But a continual seizure for more than 30 minutes. It also has to be resistant to first-line treatments. So status epilepticus patients will give them the diazepam or midazolam, and they don't come out of their seizure. They continue to fit. It is life-threatening, as I say, once you get over 30 minutes, because the brain isn't going to be getting correctly perfused. I put some of the common causes listed in NICE there. Not taking anti-epileptic medication correctly is absolutely the biggest by a long way. Commonly in the teenage group, those that are still learning to live with their illness, perhaps they're socializing and drinking a bit too much and not taking their medications correctly. They can put themselves at risk of prolonged seizures, status epilepticus. Febrile illnesses in children can cause status CP, but it is quite rare to see that. Febrile convulsions normally are very short-lived. And hemorrhagic stroke. So those of you, we were just talking about that when we were there with the hemorrhagic strokes. They can cause pressure on the brain. They can cause prolonged seizures. There's not a huge amount we can do about those. They don't respond particularly well to the diazepam, etc. So, which is obviously the paramedics' treatment of choice. Treatment for you guys at this stage is protect them from injury wherever possible, maintaining their airway if needed with a jaw thrust. So often a jaw thrust is enough, but you can consider the OP and NP option. Bearing in mind, patients that are actively fitting may well have trismus. Trismus is where your jaw clenches shut, so you won't be able to get the OP in. That's one of the main reasons why we use NPs, first line nasopharyngeal airways, inserted up the nostril, slide all the way down behind the tongue, just to hold the tongue off the back wall. Okay, just bear in mind, patients that have lots of fits, they fit quite successfully without you there. They generally don't need too much in the way of airway management. A jaw thrust is often enough. If you are going to put an NP airway in there, just bear in mind you are going to have to take that out of the patient when they kind of regain consciousness at some stage. That's not particularly pleasant. 100% oxygen is indicated during the active convulsion as per JR-Calc, and once the seizure subsides, provided their saturations are nice and stable, we can remove that oxygen. Call for senior clinical support, as I said, I've already said, it's either 999 if you're on your day off, and obviously getting a paramedic down to you if the seizure goes on for more than 5 minutes, or if any of those red flags we discussed, first time seizures, pregnancy, recent water exposure, head injuries, all that type of stuff. If any of that's gone on, then call straight away. You don't need to wait the old 5 minutes. As the seizure subsides, then recovery position is generally the best place for them, and calm and reassure the patient will be able to hear you, although they will be confused and a little bit combative. Full set of observations, including blood sugar. Blood sugar can be, drops can be a cause of seizures or provoke seizures. And considering an ECG if the patient isn't known to fit, some cardiac rhythm disturbances can cause seizures. And then, of course, transport to hospital if appropriate. So I've left it as if appropriate because every seizure is going to be handled slightly differently. First presentation seizures or any red flags are always going to go to hospital provided the patient consents. If they have epilepsy or have a diagnosis of recurrent seizures and they've had a normal for them seizure and they come round and they fully recover, then why would we take them to hospital? That's up to the patient to decide what they would like to do for the rest of the day. Be prepared for repeat seizures though, especially in those patients that have prolonged postictal phases. They're the ones that tend to just refit on you. So Excellent. One more interactive bit here, and then we'll just talk briefly about meningitis because there's not a huge amount to discuss there. So, which of the following fitting patients require immediate assistance from a paramedic? So, you assume you're a FREC 3 on an event, FREC 4 on an event, and you've got a patient fitting at the finish line or something like that. Which of the following which require assistance from the paramedic? A, B, C, or D? So you've got a 15-year-old boy with a diagnosis of epilepsy who's been fitting for 2 minutes, a 54-year-old male who's known to have alcohol withdrawal seizures, 25-year-old female who's been administered buccal midazolam and has stopped fitting, a 19-year-old female who fell off a boat earlier into the sea earlier in the day. Just to clarify, buccal midazolam is a medication that's prescribed to patients that have seizures regularly, and it's designed to be used by the patient's kind of next of kin or carers, etc., to control their seizures without the need for an ambulance to be called. So that's what buccal midazolam is for those of you that haven't come across it. Good, so let's see where people are going. Oh. Not working. There we go. So the 15-year-old boy with a diagnosis of epilepsy, 17% of you have said that. The overwhelming majority have said the 19-year-old female who fell off a boat into the sea earlier in that day. The 15-year-old with a diagnosis of epilepsy who's only been fitting for 2 minutes. That's fine. That's less than 5 minutes. He has a diagnosis. It's not his first fit. I wouldn't necessarily rush for paramedic support in that case. Of course, if you feel you need it, absolutely fine to call for it. But of course, the most correct answer, or single best answer there is the 19-year-old who fell into the sea. How do we know that she's not having some episode of secondary drowning and having a hypoxic fit as a result? So, well done. Next question. Same code, menti.com 96949086. What is meningitis? Infection, good. Infection of the meninges, bacterial and viral, good. Good. Inflammation, bacterial, infection, viral, infection of meninges, very good. I mean, there's not much more to say about it, really, is there? Meningitis is quite a simple illness. It's a horrible illness, but it's pretty simple in how it works. So, well done. Let's flip back to, yeah, a lot of people, CNS, central nervous system infection, very good. I'm happy. People know pretty much what meningitis is. See, that's great. Here we are, meningitis management then. So this diagram again, the meninges, we told you about 3 layers of the meninges, particularly the arachnoid mater and that subarachnoid space. When we get infection in there, it spreads like wildfire. So if you get bacteria growing within the cerebrospinal fluid, the CSF, between the arachnoid and pia mater, that's where it's all swimming around, bacteria breeds fairly happily in that space. Okay, there's not a huge amount the immune system can do about it. It's just perfect breeding ground. It's a bit of a weak point. The thing is that's very close to the brain. It does lots and lots of naughty things, and that spreads like wildfire. The CSF circulates all around the spinal cord, and before you know it, the immune system is completely overwhelmed. Now, as people have said, it can be bacterial or can be viral. Bacterial is by far the worst. Bacterial meningitis can kill people in hours. Viral meningitis will make you very, very unwell, but generally your immune system does get on top of it, and outcomes are generally quite good. Generally good. Bacterial meningitis often ends in death, and quite commonly ends in amputation and serious kind of neurological damage and long-term disability as a result. So not a nice disease. I think most people know somebody that's been affected by meningitis. And I've certainly been to a couple of meningitis cases out in the community that have turned out to have very kind of sad outcomes. So it is a nasty disease. So we do need to be aware of it. And the recognition symptoms, which can be recognition of meningitis, can be really quite difficult. So meningitis, it's inflammation of protective layers of the brain and meninges. It is absolutely a life-threatening emergency and definitely can kill within hours. I can testify to that. can affect anyone, although it is most common in young people. The two predominant age groups, first year of school, first year of uni, and that's when we change our social circles the most, really, and we're exposed to kind of wider ranges of bacteria and illnesses and things like that. And it's those times that we're often exposed to the bacteria that cause meningitis. It spreads in the same way that that a lot of kind of viral and bacterial upper respiratory illnesses are spread, often through nose droplets and spittle. And same with COVID spread, to be fair, and most other kind of influenzas and things like that. It settles nicely in the meninges, in the subarachnoid space, and it spreads like wildfire, as I say, and overwhelms the immune system. Coming bacterial or viral, as we said, bacterial is definitely by far the worst. Viral is still going to make you feel rubbish, though, for a good number of days. There are vaccines for the most common strains, but of course, like everything, it is still possible to contract meningitis, though, even if you're not vaccinated. We now vaccinate all first-year uni students, then we get the ACWY strain, which is a big step forward. So, recognition of meningitis, though, is quite difficult. I say because we actually the signs and symptoms of meningitis are not specific. You can show a lot of these signs and symptoms with any illness. Certainly severe headache, fever, vomiting, stiff neck, just like a bright light. I mean, they're not specific to meningitis. It's headache and feeling feverish and wanting to vomit, not wanting anyone to shine lights in your eyes, etc. That's the common cold and flu can give you that. Confusion and delirium, I think, whilst it's not specific to meningitis, it's still a bit of a red flag, isn't it? So if you've got a patient that's confused or delirious with infection, you've got to consider whether they're septic. We'll come on to that in a future webinar. Particularly kids, you've got to be a little bit careful when they're getting confused and delirious with fever. Breathlessness, again, not specific to meningitis. Any upper respiratory illness or lower respiratory illness is going to cause breathlessness. Limb, joint and muscle pain, again, is a feature of rising temperature. So not all children or adults, for that matter, that have joint pain as a result of a fever and are going to have meningitis. Cold hands and feet and shivering, and if we look at pale and mottled skin, those in conjunction are signs that circulation is failing, particularly in children. So again, there's starts of red flags, aren't they? But they're not specific to meningitis. The rash isn't that useful because it's a very late stage. Again, not completely specific to meningitis, although that the rash that doesn't disappear when you rub a tumbler over it, the non-blanching rash. It's a sign of sepsis. It's not specific to meningitis, but obviously, clearly, anyone with a non-blanching rash is very unwell until proven otherwise. Very sleepy, vacant, drowsy, difficult to wake, that type of thing. Again, not specific to meningitis, and anyone that's unwell is potentially going to be a bit kind of vacant, difficult to wake, perhaps. Again, still a bit of a red flag for kids, isn't it? Seizures. I think if you're having seizures in the context of an infection, we've got to make sure it's not meningitis. First presentation, febrile convulsions that we talked about a little while ago, they always go to hospital just to rule out meningitis as a potential cause. So I think you can see that diagnosing meningitis is going to be very difficult because actually a lot of these signs and symptoms don't necessarily just point to meningitis. They could just be the common cold. They could be teething. They could have a urine infection. They could have, of course, it had some dodgy food poisoning going on. There's lots of things here that will make your child or an adult show these symptoms, and it's not necessarily meningitis. But of course, the time it is meningitis, we all tend to say, oh, it's more likely to be a chest infection or it's more likely to be a urine infection, and that's when we miss things. So the rash, we'll show you some pictures of the rash here. This is an example of a non-blanching rash. It's a sign of sepsis, septicemia. Septic blood is what septicemia means. It is a sign of sepsis rather than specifically meningitis, but of course we all equate it with meningitis. It's interesting that it only appears in around 40% of cases, and actually it's a very, very late stage. If you've got a patient showing the non-blanching rash, things are very advanced by then. That patient is very unwell, and they're likely at the stage of losing limbs and life-changing illness and injury, if not death, if at that stage, if you're not already in the hospital. So just bear that in mind when we think about, certainly before I did this job, you just think of meningitis as being just like a bright light, stiff neck and having this rash. Actually, this rash, if they've got it, their days are numbered unless you're very close to hospital. And the just like a bright lights and stiff neck actually can occur in just about every fever. Although when you start to it's all about clinical judgment, isn't it? When you start to put things together and think, well, it could be meningitis, then you have to kind of act on it. Good. Treatment at this stage for meningitis is nice and simple. Okay, it's full set of observations. Make sure you get their News 2 score or their POPS score. We're going to come on to POPS on Paediatric Assessment. 100% oxygen, because it's in children, it's a seriously unwell child. In adults, we're treating them for sepsis. Senior clinical support or rapid transport to the nearest A&E. Paramedics do give benzopenicillin pre-hospital, which is a broad-spectrum antibiotic that is pretty good at targeting meningitis. Most of the common bacterial meningitis organisms. That being said, I wouldn't delay for too long on scene to wait for them to turn up. I think it's better that you're heading towards hospital and definitive treatment if you're suspecting meningitis. But if a paramedic's nearby, it is the earlier we get that benzopenicillin in, the better. So obs, oxygen and go. So it's a nice easy one really in terms of treatment. Monitor en route, sorry, it's the last little tab there. Those patients can deteriorate quite quickly. Just make sure you spot them becoming peri-arrest. So that's everything from tonight. Well done. Thank you very much, guys, for coming along. I hope that was useful. If you have any questions, then please feel free to chuck them in the chat. If not, we're back again next Monday at 7 o'clock. We're going to be doing abdominal pathology. So we're going to be looking at some common causes of abdominal pain, which are quite useful. So if that's useful, then come along and join us next Monday night at 7 o'clock. The Zoom link, Zoom registration, no, I've lied on here. The Zoom registration isn't quite open on Facebook. I'll put that up tonight. So check our Facebook page later tonight, tomorrow morning. You'll be able to register for next week's session. And also you'll get the reminder email on the day too. If you want to get your CPD certificate, because I'm on my own, I haven't had a chance to copy and paste the link, so please check our Facebook page. I will get you the link to our CPD certificate. That will go up when I upload the video, so just hang fire for the CPD certificate. It will be available to collect. You just fill out the feedback form as you normally do, and you'll get a PDF copy. So check our Facebook page for the PDF link. Those of you that don't have any questions, please feel free to head off and enjoy your evening, and we'll see you next Monday. If you'd like to leave us a review, it's always gratefully received. It brings more people to our business and allows us to keep these webinars free. So if you've got a spare minute just to leave us a review on one of those platforms, we'd appreciate it. And as I say, check our Facebook page tonight or tomorrow morning. I'll put the link for next week's session and the link for the certificate. Have a great evening and more than welcome, everyone. Just check there's no questions. So you're more than welcome, everyone. So I'll take any questions if anyone has any. If not, or if you think of something later, just drop them in an email to us, not a problem.